Hello, good evening, everybody, and welcome to our webinar this evening. My name is Kathy Yelf, and I'm the Chief Executive. And as ever, we are absolutely thrilled to see you all this evening. It's absolutely great to see you joining. We've got another fascinating and important talk for you tonight, actually. We have an eminent expert, as ever, and as ever, you'll be able to ask questions of this eminent expert at the end of his talk. So please do put your questions in the chat, and we will come to as many as we can a bit later on. Now, tonight, my guest is Dr. Hari Jayaram from Moorfields Eye Hospital. Hari has the most amazing CV. He did his medical training at Cambridge and Oxford universities, as well as Keele and UCL in London, and St Thomas's in London, and Moorfields itself. And he won a 2-year research scholarship to the KCI Institute of Portland, Oregon in the USA. This is very impressive, isn't it? Now, Hari is in fact a glaucoma specialist. In fact, he is the director of the glaucoma service at Moorfields. So why is he here talking to people with macular degeneration? Well, I know lots of people on this on our calls do have glaucoma, but that is not actually why he is here. Hari has been studying the impact of the COVID pandemic on eye patients, particularly people with glaucoma, age-related macular degeneration, and diabetic eye disease. And his question, I think, was, and he's going to tell us in a minute, how did patients cope during the pandemic? What effect did it have on them, particularly on their mental well-being? Now, I imagine you will have completely your own experience of this, but Hari now has some important data to share with us that gives us really the bigger picture. And this is a very important thing for us to understand as we come out of the pandemic, we hope. Hari, thank you very much indeed for joining us. I'm sorry you've had difficulty joining this evening properly, but I'm going to hand over to you now and listen to the information and the very important results that you found from your study. So, ladies and gentlemen, Hari Jayaram.
Thank you, Kathy. So I just want to check you can all hear me fine. Perfect. So Kathy and the Macular Society, thank you so much for your invite to join everyone this evening. So I'm not going to use any slides or anything traditional like that. I'm just going to talk to you about what we did. So, yes, I'm a glaucoma specialist. So as Kathy said, what on earth am I doing here talking to all of you guys who are part of an amazing UK charity looking after macular disease? Well, the COVID pandemic caused, utter chaos for individuals, families, patients, healthcare systems. At Moorfields itself, within the glaucoma service, 30th of March 2020, which feels like a lifetime away. It's very, very surreal. We cancelled about 40,000 appointments into the ether. Our retinal clinics pretty much did the same as well. And then there was a real fine balance between, what were people worried about? Were they worried about picking up COVID and passing it on to their family and, perhaps the risk of death to them or their loved ones? Or were they worried about their eye disease and the potential that they could lose vision? I mean, what was interesting is one of the first things that led to this study was we looked at what patients were worried about, of the patients that were having to come in, during lockdown 1. So we really pared back services. So it was really patients at the absolute highest risk that came in, those that needed surgery, that were at risk of losing their sight. And what was interesting was, although everyone was very worried about the pandemic, those patients that came in were more worried about their eye condition. One individual said to me, "Well, if I lose my sight, what doesn't really matter if I get COVID or not." And it was that was quite a challenging conversation to have. And what this really highlighted to all of us, both within the glaucoma service and the retina service, which are the two biggest services at Moorfields, was that, during the pandemic, and we talk about post-COVID, but, COVID didn't really go away, did it? It was around and causing problems for about 18 months or so. And we know that it caused a lot of social stresses, a lot of worry and a lot of anxiety. And there is, published data that was published probably towards the end of that year, early 2021, that showed that the prevalence of mental health issues significantly rose as a consequence of and during the pandemic. And principally, these were depressive disorders, so depression and significant anxiety. And we know this talking to colleagues who specialize in psychiatry. Even now, the burden and the wait times for a psychiatry assessment, both in the NHS and the private sector, are huge. On a personal level, I was trying to organise for a family member, trying to organise a mental health consultation. There were huge waits in the NHS. I tried to find, this is outside of London. I tried to find an appointment in the private sector. I couldn't get an appointment for 4 months. So I think this is reflective of the sheer stress and worry and pressure that the pandemic faced on the UK population as a whole. Now, this led us to think about eye disease and patients in particular with chronic eye disease. So the two major conditions that are followed up at Moorfields and monitored, that are two of the leading causes of irreversible visual impairment in the world, are glaucoma and retinal disease, including age-related macular degeneration, retinal vascular occlusions, and diabetic retinopathy. And what is unknown, what we didn't know, was how common are underlying mental health issues. Before the pandemic, we'd never even thought about it. We hadn't really, we were very focused on dealing with what we could deal with in the clinic. And in hindsight, as I'll talk about afterwards, I don't think we were as holistic as we could have been, or certainly I think ophthalmology as a whole, I don't think we're as holistic as we ought to be. There is significant data out there to show that where people do suffer from problems with their mental well-being, be that depression or anxiety, the clinical outcomes are worse. That could be for various reasons. It could be due to non-adherence with medication, not attending appointments. So the issue, from a perspective of someone that runs glaucoma services, and from my my co-investigator, Professor Shobha Shivaprasad, who's one of our leading experts in diabetic retinopathy and medical retina conditions at Moorfields, we were worried that this underlying increase in mental health problems and impairment to mental well-being could potentially have negative outcomes on our negative impact on our patients' outcomes. So as responsible ophthalmologists, if we want our patients to do as well as we possibly can, we need to look after all aspects of their care that can potentially influence that. So that led us to look at the literature. And the bottom line is, we were trying to find out what's the prevalence, how common is our underlying mental health issues in populations of patients with chronic eye disease within the UK. And the answer was nobody really knew. There was very, very little data from the UK in the literature. There are a few small studies looking at a few hundred patients from America and Europe, but there was almost nothing from the United Kingdom. So if we're trying to work out how we can incorporate addressing these sorts of issues within our holistic care in the future, we needed to first of all find out the extent of the problem. So this is what we did, and this was quite a long study actually, and this was funded with kind support from the Macular Society. Bayer, one of the pharmaceutical companies, provided some support, and also some research funds from Moorfields helped us get this in place. As well as, interestingly, we got some support from a fund set up by Captain Tom, the retired army officer who'd walked lots in his garden during the pandemic. So his charity supported this study as well. So over about a 15-month period, finishing in it was actually end of July last year, so July 2022, we basically approached patients who were attending either glaucoma or retina follow-up appointments across the Moorfields network. So Moorfields covers quite a large catchment area. We have our main hospital and our diagnostic hubs within central London. And we also have a lot of hospital-based sites in Northwest London, South London, and East London. So we approached, quite a large number of patients over this time period, and with their consent, we asked them to complete some validated questionnaires that enable the quantification and characterization of the major disorders, which were depression and anxiety. And we also looked at some of their other medical problems and collected all this information anonymously, so that they couldn't be identified, of course, just to try to look for any potential factors that may predict the likelihood of somebody having problems with their mental well-being. So during this study period, we actually approached and recruited almost 2,500 patients. So half of those were those from retina clinics, and half of those were from glaucoma clinics. And I think this is one of the advantages we have at Moorfields, is we look after so many patients over such a large population and geographical area. We're fortunate to be able to conduct research like this, and our patients are very willing to help and take part. So we're really, really grateful for any of you that are listening today that may have participated in this study as well. What this then enabled us to do was really to try to look at, how common are problems with mental well-being in this population. We didn't really know what we were going to find. We assumed it would be, there would be a burden of mental well-being problems in this patient population, which is understandable. If you have problems, if you have a condition affecting your eyesight, it's perfectly understandable that you would be this could cause symptoms and signs of depression and anxiety. So we were expecting this, but I don't think we were expecting quite the significance that we found in this group. So the take-home numbers that we found were that of glaucoma patients, 11% had clinically significant depression that would normally warrant referral onto a mental health practitioner or counsellor. And for retinal disease, that figure was higher, and it was about 14%. So that's, just to put it in context, that means that 1 in 10 of every glaucoma patient attending a clinic, or 1 in 7 when we look at retina patients, have clinically significant depression or depressive disorder that would warrant further workup, be that counselling, treatment, or intervention. If this were to be picked up. And we were very lucky with our collaborators in this project. So we worked with the Department of Psychology at UCL, which is led by a gentleman called Professor Steve Pilling. And Steve Pilling is one of the leading experts in the UK on community mental health problems. And he, in fact, I think he wrote the NICE guidance for how these issues ought to be managed in the community, and he helped develop sort of community access schemes within the London region. So we were very grateful for his and his team's input on this. So that was depression. So 1 in 10 glaucoma patients and 1 in 7 retina patients had clinically significant depression. So in terms of generalized anxiety disorder, there wasn't a huge difference between glaucoma and retina patients, but what we found was that it was a similar sort of figure. So it was about 15% of patients in glaucoma and retina clinics had significant anxiety. So that again equates to about 1 in 7 or 1 in 8 patients who are having this problem. And I have to say, we did ask the question, have you been diagnosed previously with a problem with your mental health? And almost unanimously the answer was no. So these cases that we were seeing were new cases that were picked up that had otherwise not been identified. So really, that this goes to show that there is a significant burden of mental health problems in our outpatient clinics that A, we know nothing about, B, patients have not been diagnosed, and therefore their GPs don't have any idea that this is prevalent, which then goes on to think 1 in 7 patients are living with this, not even aware that they have this issue that potentially can be treated and help hopefully improve their quality of life. So it really makes us wonder, what can we do in the future to try to address this? And I think in the discussion, I'd be really interested to hear your views about, from a patient perspective, about how you would like providers of hospital-based eye care to take this forward, and your feedback would be very, very, very much appreciated. The other analysis that the clever psychologist did was to look at this huge data set of 2,500 patients and look for patient factors that were potentially able to predict which patients may be at higher risk of having problems with depression or anxiety. It was clear from the data that patients in retina clinics were more likely to be affected than patients in glaucoma clinics. Now, we don't know why that is. If I was to speculate, I would say that from the glaucoma patients, many of these patients had more stable and earlier disease, because when we were sampling patients, these were taken from our more stable clinics. Whereas I suspect even if you have stable retinal disease, you may well have macular problems and have problems with your central vision, which are much more debilitating potentially than mild to moderate glaucoma. So that could explain why being in a medical retina clinic was a predictive factor of problems compared to glaucoma. Interestingly, we found that patients of a younger age were more likely to have problems. There seemed to be a predisposition for females more than males, male patients, to be at risk of anxiety and depression. And also, the other interesting fact was that if you came from an ethnic minority other than white British, you were more likely to have a clinically significant anxiety and depression. So these are interesting points that we ought to investigate further and try to understand more, especially whilst when we're trying to make sure that we have good equality and inclusiveness and diversity within the care that we deliver. So they were the real predictive factors. So really the take homes are clinically significant depression and anxiety are very, very prevalent in retina clinics and glaucoma clinics throughout the UK. This is something that hasn't been identified or quantified before. And really it leads on to the future. So how can we, now that we have identified that this is a potential problem, how can we change our practice or modify our practice to take this into account? One of the things that we are hoping to do is to take advantage of technology. A lot of, and certainly during the pandemic, there was a lot of work in terms of a lot of studies done online and using smartphones to access techniques such as mindfulness and meditation that can hopefully be used as initial sort of behavioral therapies to alleviate the symptoms of depression and anxiety. And what we're hoping to do is potentially look at potential trial designs about how we can incorporate evaluating the effectiveness of these sorts of interventions in patients who attend clinics. I think it's very important for us to liaise with patients' healthcare providers, so their GPs, to see that how to understand how we can help signpost our patients better. And I think probably the most important step next is to engage with people like yourself, our patients, to understand what you think would be a good next step. And that's sort of a discussion I'd love to hear your views and opinions today. And moving forward, at Moorfields, we're very lucky because we have a biomedical research centre focused on ophthalmology research, and we have a fantastic patient engagement group where they're great at sort of organising some focus groups and discussion groups where perhaps we can explore this future, in more depth in the future. But really, I think what I learned from this is that it's all very well being able to control someone's eye pressure in our glaucoma clinics and give people injections to reduce their macular fluid in our retina clinics, and laser treatment as needed. But ultimately, that's just one small facet of how your eye problem is potentially affecting your day-to-day function, your quality of life, and your existence as a independent person. And I think as eye care providers and doctors on the whole, we need to somehow be more holistic within the constraints of reduced NHS funding and budgets to be able to look after people as a whole, because this is another aspect of people's lives that hopefully we can identify and improve other than just their eyesight. So that was, Kathy, that was all I really wanted to say today, but I'd be really interested in your thoughts and just any sort of insights from people on the call today who may or may not have underlying issues with anxiety and depression, whether they feel that's related to their eye problems, their eye care, the anxiety of having to come into hospitals and having things done to your eyes, which for anybody will make you anxious. But thank you again for the opportunity to speak to you all tonight. It's been a real honour. So thank you for that, Kathy.
No, well, thank you, Harry. That was really, really interesting. So yes, exactly. So there's somebody on the chat immediately who said having injections in your eyes causes anxiety, which for many people you completely understand. Nobody would wish to go through that, would they? So Harry is inviting you to tell him how you feel about your eye condition. What made you anxious, if anything, about it? What stopped you being anxious about it? What was good and what was bad? What absolutely terrified you? What was the diagnosis, the diagnostic appointment like? Tell us a little bit about your experiences, because you've got somebody here who has open ears who wants to hear about it. So here's your chance. Get some comments in the chat. Even if you haven't got any questions, put some comments in the chat, because here's your opportunity to tell people how you actually feel. It is, I mean, there is a question here about clearly COVID made lots of people anxious. Do we know whether people with eye disease were more anxious than people without eye disease? Because we were all made anxious a bit by COVID, weren't we?
I mean, what was interesting was, we don't know the answer to that question, but what I found was interesting was, and we carried out this survey in around May, June 2020. So this was when all the curves of hospitalization and deaths were going through the roof. Yet people who needed to be seen in a hospital eye setting at that stage, they were much, because we asked them, are you worried about catching COVID coming into a hospital? What are you more worried about, COVID or your eye disease? It was unanimous that people were more worried about their vision and losing sight than they were about catching COVID, which was interesting because, I guess the control group was the doctors in the hospital. We were, obviously, to our knowledge, don't have any eye problems that we know of, but we were all terrified of what was happening, in the outside world with, colleagues in other specialties. And, at that stage, we hadn't been asked to volunteer in other hospitals yet. But we were sort of much more acutely aware of the COVID risk on a personal level, because we didn't have the insight into the risk of potential cancelled appointments, missing your appointments, and actually, with the benefit of hindsight, I think that was justified from our patients, because it was only over the last 18 months or so, and I can't speak from the retina site point of view, but certainly from glaucoma, not just at Moorfields, but across the country, there are cases that we only found out about now, about multiple, COVID deferrals. People have missed their appointments, not through any fault of their own, just because of hospital cancellations and a lack of capacity, and have lost sight. So, with the benefit of hindsight, I think, I think that judgment call from our patients was correct, even though we didn't know it at the time.
Yeah, I mean, certainly our advice line, our helpline, took many, many, many calls from patients who wanted advice about what should I do? Do I risk my life and go out and go to the hospital, or do I risk my sight and stay at home? And it was a very horrible decision for people to make, and there was undoubtedly a great deal of anxiety about that. In a way, I'm sort of surprised not. I'm sort of not surprised about it, because we know we've known for such a long time that people fear sight loss such a lot, and fear is that word, really. It really is. And I guess if you have a condition that threatens your sight, that fear is much more real than a theoretical fear about getting COVID and so on. So in a way, I'm not so surprised. One point here that somebody's come in, and this is very common. We completely know this. Waiting for appointments and having to keep ringing to get them is a very stressful thing. And I'd say some clinics seem to be very much better at this, managing this than others. Some clinics, people say they get their next appointment when they leave the clinic, and other people have to put their entire life on hold for weeks and weeks on end, because they never know when this all important appointment is going to come through. They didn't go on holiday, they can't commit to having the grandchildren. It's a really stressful thing that affects the whole of their life, really.
I mean, it's interesting because I can completely empathize with that. I had some health issues after COVID, so I've sort of seen it on the other side as being a patient. And I remember trying to change. I vividly remember this. I was on the way to work and I was trying to change an outpatient appointment at the Royal Free, and I was on hold for about 45 minutes on the tube platform because I didn't want to go underground. And it said, I started off as number 30 in the queue, then I got down to number 1, and then I got put through, and then it disconnected. And then and these are sort of experiences that I know most patients have, and it is really, really frustrating. What lots of hospitals are trying to do now are to reduce the need to phone in. Now, this is a tricky one because it again is reliant on technology to some extent. So there are some hospitals now that that you can request to change your appointment online. So actually, what I had to do a few weeks ago, I needed to change an appointment. So I filled in a web form, pressed click, and someone phoned me within about 10 minutes. And it's like, okay, this is pretty cool. At Moorfields, one of the things we're embracing is there is a sort of a platform called Doctor Doctor, and it's sort of a text message, smartphone system that's integrated with our electronic medical record. So during the pandemic, we were piloting this to canvass patient feedback and also administer questionnaires for projects. And so so these are things that can be used to change appointments. My only concern is if you have very poor central vision, or if you are registered as severe sight impaired, it may not be appropriate. And this sort of this phenomenon that we call digital discrimination is, we're very aware of it, because if it was my mum trying to change her appointment on a text message, it's not going to happen. And especially for macular disease and glaucoma, our patients are generally of more mature age and less. People never always amaze me with their technical prowess, but I always think about my mum, and my mum, wouldn't be able to do this. So that's my sort of promise.
It's digital sort of savviness, but it's also the availability. We have a digitally savvy audience tonight, obviously, because they're here. But I mean, we know that we don't reach many people who simply cannot afford a smartphone, or don't have a laptop. Even if they were capable of using one, they haven't got one. So yeah, it is a real issue, isn't it? Relying on that technology increasingly and forgetting that actually a lot of people don't actually have it. There's an interesting point here about waiting for appointments. So this is receiving a diagnosis of macular degeneration was anxiety inducing. Looking back, it would have been helpful if the consultant could have asked if I needed some emotional support. I appreciate they're very busy, and that's the rub often, isn't it?
Yeah, well, I think you've hit the nail on the head, and this is what this study has really, shown us, is that, and I think it's the same for glaucoma and retina clinics. When we, one of the things that I think we're, giving the treatment and the correct treatment and surgery, I think we do that very well. What we don't do so well, and definitely could do better on, is looking at explaining the condition, looking at talking about prognosis, and like you said, looking at the emotional side of it. And I think I don't think there's any, if you took any ophthalmologist in the UK that thinks they that's done well in their clinics, I think we all uniformly will say we could do better in that for sure. And I'm not trying to make excuses, but it's usually because the clinics are overbooked and busy, and there is a time pressure. One of the things that we've just implemented for glaucoma patients, and it would be interesting if this is something that the audience feel may be helpful for retina patients. That's something I can certainly feed back to my colleagues at Moorfields. Is for newly diagnosed glaucoma patients, yes, we talk to people about eye drops or laser or treatment, but we do refer them to information from Glaucoma UK, etc. But I don't think we spend enough time talking about it and the impact on the emotional impacts, and it's always the questions always arise when you've left the clinic, and I feel that we could improve on that to help our patients experience. So what we have started now is for all newly diagnosed patients with glaucoma, we are essentially organising for them to join an online focus group that is led by one of our specialist nurses, and it's to do with patient education and understanding. And it really, the idea is that, and I think this is a proven theory, and I'm sure it's the same for macular disease as well as glaucoma, is that the more you understand the more any of us understand about a health problem, be it an eye problem or anything else, the more likely we are to attend our appointments because we know how important they are, the more likely we are to take our tablets or eye drops. So I think it's there's two reasons.
Sorry to interrupt, but also, frankly, with macular disease particularly, to have a realistic understanding of the prognosis. So the number of people who phone us terrified that they are going to be blind, in that kind of sense that I won't see anything at all, there will just be blackness. So this understanding, the reduction of anxiety over an overblown fear of something that, although this is awful, it's not as bad as that. That's really important, I think.
And Kathy, I think that's the same for glaucoma as well, because with Dr. Google these days, you put in glaucoma or you put in macular degeneration into Google, it's terrifying. So I think the patient education clinics I think they're helpful on two fronts. One, it offers a platform and an opportunity to ask further questions. It offers some education that we probably didn't have time to give in the clinic setting. And also, I think it's a sense of community as well, because we are running these as small groups. So I think there's up to 4 to 5 people that will be joining. So it's a sense of sort of community that, you're just like today, you're not on your own. There are people there that can talk to you. There are other people with the same thing as you. And just to show that, there is a family sort of approach and everyone can help each other, because I think the support from your patient peers is hugely important.
Absolutely, we know it's so important. A point here, somebody who has macular degeneration is also immune deficient, and what makes this person very anxious is the lack of anti-COVID mitigations in so many settings, including now, of course, in the hospital. So a GP surgery is still asking patients to mask up. So this actually, the fear of COVID is still there. And of course, we're coming now into the autumn, aren't we? And there's another winter surge and a new strain potentially. So that sort of anxiety is going to start.
I mean, it's interesting, Kathy, because that's that's coming back at the moment. So my mum's 83, and I had a cousin who lives in Canada that hadn't seen her for 3.5 years, came over, spent some time with my mum, flew back, told me they were COVID positive. And then my mum's been unwell for a week, and there's all this. It's happening to all of us. Everyone knows somebody, and it makes me worry as well. Certainly at Moorfields, we were pretty good to start with. The mask wearing sort of weaned off. I stopped wearing a mask about probably not that long ago, probably about 3 months ago, but I've started wearing a mask again now. The other really interesting thing that happens at eye clinics is on the slit lamps, we have what are called breath guards. So that provides reassurance for, even if you're not masked, it provides reassurance for patients and doctors that if you're in close proximity, there is a significant barrier that's not, there's going to reduce droplet spread. My biggest worry, to be honest, and I'm sure that would be echoed by the person you mentioned there, and also others here, is the travel. Certainly in central London, traveling on the underground. So I've started wearing a mask on the underground or buses now. If there's people in my personal space, as it were. But it's interesting, isn't it? Because it's one of those things that I think we're going to, we'll have to live with and adapt, and that worry will never go away, will it?
No, I guess it won't. Actually, I was talking to a colleague today. She had developed we had two meetings in London, so we were both on the tube and on trains last week, and she has a chest infection this week. It's not COVID, she's tested, but yes, you're right. I mean, we're in that time of year, aren't we? There's another person here who has talked a little bit about, she's been having injections for 10 years, now every 4 weeks. She didn't miss one during COVID. Didn't miss one. I'm very grateful to the team in Aberdeen for keeping the show on the road. But she's saying, I now think I have been depressed. But how easy is it to find out if the depression is caused by COVID or by the injections themselves? And actually, does it matter what's caused it exactly? I don't know. What do you make of that? It's a very interesting point, isn't it?
Yeah, that's really interesting. And humans are the human psyche is a complex, multifactorial thing. We are all influenced by various domains of our life, our interactions. So it's difficult to know. I mean, like we said, we know that the COVID pandemic increased anxiety. If you're having regular injections or treatment for a potentially blinding sight-threatening disease, that's going to cause anxiety. I think what's important is, like you alluded to, Kathy, it's the fact that it's there in the, how we got there, maybe isn't the most important thing. The most important thing is that the person that made that comment has the fact that they've noticed, you're aware that something's not quite right, and having the insight to notice that is a huge deal. And that's the most important thing, because my worry, especially with this study, was that of these 1 in 7 that had problems, they didn't know they had a problem. They weren't aware of it, so they were living their lives with this sort of hanging over them, and their quality of life was clearly affected. But the fact that you've actually managed to reflect and think, actually, I am a bit down, I'm going to do something, I think that's amazing. And the fact, forget how you got there or what might have caused it, but the fact that you've identified that problem, I think, is a huge step. That means that you can now seek help to try to address it.
It's a bit of a logjam break, isn't it? So,
yeah.
So if anybody is feeling like that, or if you are just feeling a bit low and you'd just like to explore perhaps the reasons why that might be, please do. And we're going to put the telephone number in the chat. Please do call our helpline, chat to them, and they will refer you onto our completely free counselling service. And our wonderful counsellors will help you unravel a little bit of that, so that you will be able to understand a bit more about why you are where you are, and that makes it hugely more manageable, and it feels like a problem that you can solve rather than something where you don't even know where it's coming from. So I do urge you, do give our helpline a ring in the morning if you're feeling a bit low. We're going to put the number in the chat, and I'll give it out at the end, and then you can take advantage of that. Please do, because we can really help support you over that. That would be really good.
Absolutely, because I think what we're very lucky in the UK is, certainly for with the Macular Society and Glaucoma UK, their patient helplines are fantastic and offer such support to everybody. On the other thing that you could always look at, and this varies depending on where you live in the UK, but there is so Professor Pilling, who we worked with on this study, he helped develop this program nationwide called Improving Access to Psychological Therapies. So the sort of acronym is IAPT, so IAPT. So if you just put that into Google, that will tell you a little bit more about what may be available in your local area. And you don't even need a GP referral for this. You can self-refer to this if you're feeling a bit down, or whether it's stress, anxiety, or low mood. you can self-refer. The other thing, of course, is to, just have a chat with your GP. You don't need to see them, again, it's not, I know that that's another worry, isn't it, getting GP appointments, but for this sort of thing, it might be just nice to have a chat with them on the phone. And I think my personal experience is getting a telephone call from a GP is much easier than having to get a face-to-face appointment. So don't forget that your GP is a source of support as well. But absolutely, like Kathy said, the counselling line for the Macular Society, and even just putting IAPT into Google and seeing what's in your local neighbourhood or close by, you can self-refer to that.
Yeah, that's really great advice. And GPs are extremely good on this in the main, aren't they? Yeah, so if you want to know more about IAPS, you can also phone the helpline if you're not sure about how to access that, and they can give you some advice on that as well. So that's really good. Now, here's something that does wind people up, doesn't it? Patient information. My patient information says I can email the AMD coordinator, but she almost never answers the emails. I mean, that's the sort of unfulfilled promise, isn't it? You think you've got a route to support, but actually it's a bit of a cul-de-sac. It doesn't actually work. So stressful, isn't it, that?
It is, and it's very, very difficult. So during the pandemic, we created an email helpline, and I cannot explain to you the volume of emails that we received. We thought it would be, the person that was on call that day might be able to handle it, but we were getting up to 50 to 100 email inquiries per day from not just patients at Moorfields, but from everywhere. And it was a real challenge to respond to things. So for the glaucoma service, we actually, once the pandemic had sort of calmed down a bit, we withdrew that. We at Moorfields, we still have a patient helpline that is staffed, so you can phone up and speak to one of our nurses on the phone, and they quite often will be able to then, without you having to do the chasing, signpost you to the, for example, I will quite often get an email saying this patient is seen in this clinic, they're worried about XYZ, can you, and then I can then signpost things to the relevant people. But yes, I totally agree, it is a challenge. I think our retina clinics at Moorfields still have the email address there, and they've managed to maintain responses. But yeah, I completely empathize with that.
How typical, also, to be fair, is Moorfields? I mean, you are a unique resource, Moorfields, aren't you? How much is that replicated around?
I think we're a bit of an outlier, obviously, because of the sheer number of patients we have. So we are able to do things because we have a lot of staff. So for glaucoma, and I think we have 27 glaucoma consultants, and I think at last count about 32 retina consultants, and similar numbers of clinical fellows and optometrists who are incredibly skilled. So we are fortunate that we can deliver the type of service that we do. I mean, that's one of the reasons why, in terms of, you've probably heard about what we call diagnostic hubs for monitoring. So rather than coming to sit in a clinic for 3 hours in a stuffed waiting room, you can now come and have your OCT scans done in some circumstances in a shopping centre. So we opened one for research, where we sort of redesigned it iteratively up at Brent Cross Shopping Centre. So we've managed to sort of and the impact of that is just coming through now. It had a huge impact on reducing the delays from COVID. We managed to clear our COVID backlog within several months, whereas the rest of the country was struggling. But we were only able to do that really because of the sheer size of the beast, I guess. It is difficult. So if your local hospital is much smaller, it might be trickier. Having said that, if your local hospital is smaller, I would have thought that if you were to phone up or drop them an email, you're more likely to get a response quicker than you would at a bigger hospital.
Interesting research study, that. Here's a tip. Somebody says the book prescriptions scheme, of which I've never heard, where GPs can prescribe a self-help book for mild mental health issues, mild anxiety, to be borrowed from local libraries, is useful. Not sure if it's extended to include audio books and large print and so on, but might be worth asking your local your local library, so the book prescription scheme, so the GP is giving advice on what to read to help. That's quite an interesting thing, isn't it?
So that's really interesting. I hadn't heard of that. So that's
No.
interesting. I mean, I'd be interested to know whether has anybody on this call used any sort of app-based therapies, to help sort of relaxation or to address stress or anxiety, because that's something that what we'd like to do is ideally approach some two cohorts of patients and try one app versus another based on what our psychologists recommend, and just see if we can demonstrate a benefit. Because I'm pretty sure we can, but you know what it's like with the NHS, to try to get NICE or anyone to sort of support something, you have to generate evidence. So we've done the first step in showing that there's a problem, but what I'd like to do next is try to demonstrate how, whilst you are waiting for your appointment or waiting for your pupils to dilate, perhaps we can recommend something that will help with your mental well-being and help address your anxiety in a non-pharmacological, without needing drugs, ideally.
That's a very really good idea, and they do it in other disease areas, don't they? So there's no reason why it shouldn't be done here. Here's a common problem, I think. I have a laptop and a smartphone, but it's very difficult for me to find the right buttons to press.
Yeah.
So I'm just going to give a little ad here for the Tech Talk service. So you can email or phone our office and ask for the Tech Talk service, techtalk@macularsociety.org. And we have people who can help you overcome some of these things, perhaps, for example, by exploring what the voice control mechanisms might be on your phone. So you don't have to press a button, you just talk to the phone and it does it for you. I don't know what kind of phone you've got, but anyway, techtalk@macularsociety.org. If you're struggling with technology, we might be able to help with that. Another one here about seeing, here in York, we have a liaison officer, an eye clinic liaison officer, and connected this person to the local charity in York, and this was after they saw a consultant. Very reassuring. So this signposting on to support, because I guess we don't expect, and I think sometimes the NHS thinks everybody does expect the clinic to provide everything, but actually there's a lot of other stuff around. If they signposted efficiently and effectively, people would find a lot of the support that helps.
It's interesting, because I think most eye units in the UK will have an eye clinic liaison officer. We tend to, we tend to work with the eye clinic, or we call them ECLOs. That's the short name. You might hear people talk about ECLOs. And we work with them to help support our patients with quite significant visual impairment. So if we are registering somebody as sight impaired or severely sight impaired, we would routinely, and I think this is the same for most eye units, we would, we would, as the clinician, we would fill in the paperwork, but actually the eye clinic liaison officers will speak to the patients and really explain to them what's available, what help they can get from their local council, if it involves a blue badge or anything like that, and also liaising with low vision clinics, and also, just like you said, Kathy, the ECLOs are a fantastic source of support, because they have contact numbers that they give out, and some of them are quite inspirational. So one of the ECLOs I work with in at Moorfields is he's himself, and he's quite inspired. I always find people with visual impairment quite inspiring, how they're so resilient and somehow manage to adapt and do everything everything that they can to be as independent as possible. So I think all our units will have an eye clinic liaison officer, and I think they're a fantastic group of people, fantastic sort of source of support.
Yeah, I don't think they are in the majority around. I don't think the majority of clinics do have them. It might be a very small majority, but also it's really interesting about when that referral happens, because it seems to me that actually quite a lot of people are anxious and depressed a lot earlier than at the point at which they are registered as sight impaired or severely sight impaired.
Absolutely.
And that's kind of too late, really, to offer them optimal support if you wait until that point, don't you think?
Well, I think so, and that I mean that was the real one of the take-home messages from this study. You know, we're looking at, you know, a general clinic population for glaucoma and retina, and we're finding 1 in 7 people have clinically significant depression or anxiety. That's not a clinic that's full of people with, you know, registered as sight impaired and severely sight impaired. This is the whole spectrum of disease, who could have actually normal vision, but, you know, they have this, their anxiety could be related to the underlying diagnosis and uncertainty about what may happen in the future. So yeah, but I totally agree. I think once, you know, we need to try and address this early rather than later. So yeah, and that's why raising awareness amongst clinicians is the next step, really.
Yeah. So there's a point here, and I'm not entirely sure what this person is saying, but it does worry me. They say, when I hear others have had their injections for 10 years or whatever, I get a feeling that I'm on the back burner. I'm not quite sure whether this person means that they haven't had enough injections, or they're worried that it's got to go on forever. But one of the issues, and I have come across this, is that there are now several drugs on the market for macular degeneration, aren't there? And people react differently to different drugs. And so there isn't absolutely a set regime, is there, or regimen for people. It's not the case that everybody will have this number of injections at this regular intervals. Everybody is different. I can understand it might make you a bit anxious if you get into a waiting room and chat to the person next to you and they say, oh, I come here every 4 weeks, and you say, well, hang on a minute, I'm only coming every 8, 10 or 12 weeks. That, you know, does that make you more anxious that actually the variability of this can make people anxious?
So I think it's, you know, this isn't my area of expertise, but I can comment on this. But we have, you know, you have to remember that everyone is different, and like you said, Kathy, people respond differently to different types of drugs, different molecules. All of the, you know, initially when injections first came out, that, you know, the clinical trials would say you need to have X number of injections over this time scale, and then we'll see how it goes. On the whole, that's changed now, and people will normally what we call treat and extend. So you'll have a couple of injections, and then because of technology, basically because of OCT scanning, it used to be you know, what we call fluorescent angiography, where you'd have the yellow dye injected, and we'd take lots of photos. That's largely been superseded by OCT imaging. So now what my retinal colleagues will be able to do is look for very, very, very subtle signs of any fluid on the scans. Then if there's no fluid, they won't inject. And it's interesting, even with glaucoma as well, some of our glaucoma laser treatments, we don't know how long they're going to last for, but what we can confidently do is stretch out the follow-up period. And so there may be people that have had more injections, there may be people that have had fewer injections. What we still can't predict is what's going to happen in the future. And I think what's important is that you definitely attend your visits, and if you do experience any new symptoms, so if you get any new, you know, central distortion or blurring, I would recommend personally just to visit your local eye casualty, especially if you haven't been seen for some time, because that may mean that you might need an injection sooner than intended, because we just don't know how the human eye is going to respond.
No, and this business about it's just come up again, really, the business about the fear of delays of appointments. So somebody who was diagnosed with macular degeneration about 3 years ago, told in no uncertain terms that they must go to all their appointments. The problem is, they say you can't get an appointment when you've been told you need them. I'm supposed to have an injection every 4 weeks, but I never get an appointment in under 7 weeks from the previous injections. That must be enormously frightening, really.
Yeah, I know. I can understand how that, and that must be very frustrating. And I think we have the same feedback from our patients with glaucoma as well. And I think this is a challenge that the NHS is still. And this was, ironically, this was a problem pre-COVID. Don't think we can attribute this to the pandemic. Clinics were always very, very busy before the pandemic, and they're, you know, still busy now, and that's something that across the NHS, all hospitals are still trying to address. that with our stable patients that just have monitoring, diagnostic hubs have a role, but it doesn't solve the problem that you've just described with where people are coming in for an active intervention and a sort of not getting that in time. One of the big changes that we have done across the NHS over the past 5 years is expanding the workforce that give injections. So at Moorfields, we have a nurse consultant who is the first to deliver injections for macular degeneration. And actually, it's not just the doctors that do this. We have very senior optometrists and nurses that give the injections and give the treatment. So what across the country, what we're trying to do to address this sort of lack of capacity and lack of numbers, clinic space, is to train additional workforce to give the injections and to be able to make the decision as to whether the injection is needed. And this is normally always done with consultant oversight. So even if you don't see the consultant in your clinic, you can be sure that he or she would have looked at your scans and at some point and said, yes, this person needs another injection. And we do that with glaucoma as well. We have stratified care where we oversee a lot of patients and help make those important decisions, although we may not actually deliver the treatment ourselves.
I mean that's great, and the skill of people who've taken on these roles, these injecting roles, is amazing, because it was never envisaged, was it, that anybody other than a consultant ophthalmologist or ophthalmologist would deliver these injections. And it's marvelous that they've been willing to take on the work. It really is, because we couldn't have had a service, could we, without them. I guess what patients are concerned about is that when do they get to talk to a doctor? When do they get to speak to the top man about their condition? And does the whole process, because of the pressure on the services, just become a kind of conveyor belt, that they're on the conveyor belt, and who is stopping and asking them how they feel and how they're coping, and do they know about the risk of hallucinations, and and actually finds out whether they're a bit depressed and anxious? Where is that really,
I think,
feasibly and realistically now in the pathway?
I mean, Kathy, that I think you've hit the nail on the head. At the moment, it's not on the pathway, and it is very much a conveyor belt. The only thing that we've tried to introduce, especially for for the injections, I would like. That's something that we need to take a look at ourselves, because if I was a patient having an injection, I would be anxious and I would want somebody to talk to me. And I've certainly seen patients who have had had a very bad experience. They feel that they're just on a production line, and all they want to do is they want to talk to someone. And I've seen people like that, and I completely understand why people feel like that. From the stable monitoring side, what we are trying to do is, because a lot of patients have been monitored in our what we call diagnostic or virtual clinics, we are trying to make sure that when they speak to our technicians, who will ask them, how are they, what problems do you have, if they have a specific concern and they want to speak to a doctor, what we are trying to do is make sure that is recorded on that attendance. And then when we review the patients, we then make a phone call, and usually we can address most concerns over a telephone consultation. And if we need to, then of course we can see people in a face-to-face clinic. But my experience is that the majority of worries and concerns can be addressed just by a bit of human interaction and conversation. And going back to when I had my health problems, I never met my GP, but I felt that the person I spoke to listened to what I had to say, and I was quite pleased with the digital consultation experience. I know every different experiences, but on the injection side, we need to make time for people, because I think we completely underestimate the impact of things. It's like cataract surgery. For us, we do it day in, day out, but the unknown, especially, and maybe the known in some situations, is a source of huge worry. And that's what this study has highlighted, that we need to be aware of this. It is a problem that can affect outcomes, and we need to somehow incorporate it into our pathway.
Well, thank you so much for paying attention to it, because I know hundreds of thousands, millions of patients will be so grateful to you for at least paying attention to this and getting the ball rolling on it. We haven't got time, we've run out of time, but I've just mentioned one thing, that a very final thing that's come in. Do you think anxiety and depression might be even more common in people with dry macular disease who don't get to a clinic at all? And that's a whole other patient population. I don't even have time to ask you for a response, but I plant that thought because it's such a very well made point. Hari, thank you so very much for joining us tonight. We're going to want to hear a lot more about your findings, and we'll keep this chat so that we can pass it on to you, so that we don't miss any of the points that people have made tonight. I'm sorry if I wasn't able to read out your point, but we had so many this evening. Thank you very, very much indeed, Hari, for joining us. I just want to remind you that we'll be here again in a month's time with another great speaker on the 17th of October, Tuesday at 7 p.m. All the talks from our conference on Saturday are now online, and you can go to our website and see any of those fantastic talks as well. And don't forget, the helpline is open 9 o'clock tomorrow morning, 0300 30 30 111. So if you want to talk about anything tonight, please do give them a call in the morning. Hari, once again, thank you very much indeed. Thank you all for joining us this evening, and have an enjoyable rest of evening. Thank you very much indeed. Good night.
Thank you. Good night.
Good night.